Hello, everyone, and good evening on the East Coast. Welcome to this webinar on NRG-LU006, the phase 3 randomized trial on trimodality therapy for patients with malignant pleural mesothelioma. This webinar is specifically focused on surgical questions, and so we have modified the slides a little bit to account for that. And we would also invite everyone to join us at the end for a live Q&A. The purpose of this webinar is really to introduce what is necessary for the surgeons on this trial, but also to answer questions for any sites that have not opened this trial yet, and any surgical questions that may come up in the process of opening the trial, getting credentialed, and any other areas in the protocol that we could help clarify. The chat should be enabled now for all attendees, but there's also a Q&A section in the bar at the bottom of the Zoom call that you could use to ask questions. I'd welcome Dr. Chuck Simone, who's the Chief Medical Officer of the New York Proton Center and another mesothelioma radiation oncology expert and co-PI on this trial, and Dr. Valerie Rouge, who is our surgical co-PI on this trial, who are joining me today as the panelists and will help field questions, especially the surgical questions. We will direct probably heavily to Dr. Rouge, but we're happy to answer any questions that you may have about this trial. Thank you for joining us today, Dr. Rouge and Dr. Simone. And with that, I'd like to start. So again, this is the phase 3 randomized trial on pleurectomy decortication, which is the lung-sparing surgery, with systemic therapy, chemotherapy, or immunotherapy, or a combination thereof, and randomizing patients to adjuvant hemithoracic intensity-modulated pleural radiation therapy called IMPRINT for patients with malignant pleural mesothelioma. As you can see here in this picture down here, IMPRINT is a very complex radiation technique that targets the entire pleural space, the diaphragm, and all the way down to L1 or L2, where the insertion of the diaphragm ends. And it is a technique that is able to spare the ipsilateral lung after lung sparing surgery, so patients with 2 intact lungs, and also spare the contralateral lung, of course, maximally. These are my disclosures. They are not related to today's presentation. And here is the full list of co-PIs on the study team. We have Dr. Zaudrow from medical oncology as the medical oncology co-PI. Then we have a whole team of medical physicists, radiologists, proton physicists, pulmonologists, pathologists, translational, as well as biostatistics from NRG, of course. So by way of background, pleurectomy decortication has become a very common lung-sparing surgical approach for patients with mesothelioma. Chemotherapy or systemic therapy can be delivered in the neoadjuvant or adjuvant setting. And this IMPRINT technique has been developed by us at Memorial Sloan Kettering Cancer Center and was tested in two phase 2 studies, first single institution, then multi-institutional, and was demonstrated to be a safe technique to follow lung-sparing surgery to kill any potential microscopic cells in the pleural space, or what used to be the pleural space. And the survival outcomes were promising enough for us to launch this phase 3 trial, which was supported by the NCTN through through the NRG Oncology Cooperative Group, and is designed to evaluate the efficacy of this approach with all 3 modalities. But in terms of surgical background, pleurectomy decortication has become increasingly popular, mostly based on several mostly retrospective studies that have compared the outcomes for these patients. On the left, you can see a retrospective pooled analysis from 3 institutions with more than 600 patients that found that the operative mortality was lower for pleurectomy decortication, and the survival was actually surprisingly higher with pleurectomy decortication, even though it is the less complete oncologic surgery, if you will, as it just removes the visceral and parietal pleura with the mesothelioma and leaves the ipsilateral lung intact. By definition, that results in an R1 resection at best, because it's not really possible to achieve a microscopically complete R0 resection. And this initial finding was confirmed by multiple studies. Here's just one example of a meta-analysis of 24 studies that was done by Dr. Taioli. And you can see that most studies favored pleurectomy decortication, and also the magnitude of how much it favored one surgery over the other seemed greater with pleurectomy decortication compared to an extrapleural pneumonectomy, which is the other type of surgery that removes the entire lung on that ipsilateral involved site. And so because of that, we designed this trial, because it leaves us as radiation oncologists with the conundrum that we have to try and target what was the pleural space without overdosing the ipsilateral lung, which is very sensitive to radiation. And if we wanted to continue to provide an adjuvant modality to kill any microscopic cells that are left behind after surgery, we needed to develop this technique that really just treats the rind all around the lung and not the lung itself. As I mentioned, this was found to be safe, and the NCI decided in its rare disease initiative that this was the most promising trial design for early stage resectable mesothelioma. The eligibility criteria in simple terms are any patient with stage 1 to 3 malignant pleural mesothelioma that is resectable or deemed resectable by lung sparing pleurectomy decortication by the surgeon is eligible for this trial. We are focusing on the epithelioid or biphasic subtype. We have excluded sarcomatoid subtype. Patients should be between 18 and 80 years and have a decent functional status, and of course pulmonary function tests that are amenable to this type of surgery. The goal of the surgery has to be a macroscopic complete resection, and then patients will undergo adjuvant chemotherapy up to 4 cycles before they get randomized 1-to-1 to receive the IMPRINT, the adjuvant radiation therapy, to the entire pleural space, or no adjuvant IMPRINT. It is permissible to have the systemic therapy before the surgery and also off protocol. So patients who come to you after having received neoadjuvant chemotherapy, or also chemotherapy, immunotherapy, or ipi/nivo per the latest amendment, they can enroll prior to surgery, get the surgery, and then get directly randomized to radiation. Intensity-modulated proton therapy is also permissible if you have access to a proton center. So the IMPRINT can be either delivered by IMRT with photons or with protons. We are stratifying the patients by the histologic subtype based on whether a macroscopic complete resection has been achieved or not, and whether they received chemotherapy or chemotherapy including immunotherapy or immunotherapy alone, ipi/nivo. This is a different way of showing the schematic of the trial, more specifically with where the registration is for the NRG registration. So if patients had neoadjuvant systemic therapy before study entry, they would go through step 1 registration, where we need to have documented pathologic confirmation of the mesothelioma and that it is deemed to be amenable to a macroscopic complete resection with a pleurectomy decortication. And then they would receive the surgery, get stratified, and then randomized to radiation or no radiation. If patients have not received neoadjuvant systemic therapy prior to enrollment, they would go for the surgery first, then receive the adjuvant chemotherapy, and then get randomized to the hemithoracic radiation or not. The key eligibility criteria for step-by-step. Prior to step 1 registration, as I mentioned, we need pathologic proof of the mesothelioma. We need surgeon input on the feasibility of the surgery, and of course, imaging per protocol with a PET-CT and a CT, an acceptable performance status, and adequate normal organ function, and of course, the consent has to be signed. I already mentioned that the permissible systemic therapies are standard platinum pemetrexed doublet, but also platinum pemetrexed and an anti-PD-1 or PD-L1 agent, or ipi/nivo, since these are newer combinations that have made their way into the management of mesothelioma more recently. Patients, if they had neoadjuvant systemic therapy, need to have received at least 2 cycles of that, up to 4 cycles prior to enrollment. And prior to the randomization, Again, patients have to have had at least 2 cycles of systemic therapy and then undergo the surgery with the goal of macroscopic complete resection. We have excluded bevacizumab as a treatment out of concerns of combining anti-angiogenic therapy with mesothelioma, even if done sequentially. Also due to potential increased complication from surgery. And of course, there's a time window for each step from systemic therapy to surgery and from surgery to radiation of each of 8 weeks. The hypothesis is that the addition of this adjuvant imprint is associated with an overall survival benefit compared to surgery and systemic therapy alone. And the primary objective is an improvement in median overall survival from 12 months, which is the null hypothesis, to 20 months. So an addition of 8 months, and it's calculated from the time of randomization, so after systemic therapy and surgery. Secondary objectives include local failure-free, distant metastasis-free, and progression-free survival, toxicities per CTCAE version 5, and quality of life, which is really important because this is obviously not an easy treatment to go through, especially with all 3 modalities. And so any survival benefit that we might see, we would also want to know what the quality of life is from the patient's perspective. And we have several exploratory endpoints as well, including further analysis of the imaging, genomic and immunologic biomarkers. We have a novel radiation planning design technique that we want to explore. And we are also checking whether the experience and how many patients each center treats has an impact on the outcome. Now, more specifically for the surgeons, what is needed for credentialing? We do require to know how many mesothelioma surgeries were done in the past 2 years, and it needs to be at least 5 per year to demonstrate adequate experience. And we also want to know the grade 4 or 5 toxicities 30 days post-operatively in the last 2 years to make sure that there's no excess toxicity in your hands. In terms of intraoperative documentation, once a patient is enrolled and treated or operated on protocol, we need the resection defined per ISLC and IMIC guidelines. So is it an extended pleurectomy decortication, a simple pleurectomy decortication, or a partial pleurectomy decortication? What was possible? We need careful documentation of the diaphragmatic, pericardial, and chest wall invasion, if there was any, for accurate T-staging. We need documentation of unresectable areas, and these areas should be clipped to guide the adjuvant radiation therapy. And we do not allow intraoperative adjunctive therapies such as heated chemotherapy, photodynamic therapy, or what else your favorite intraoperative adjunctive therapy might be. We also do require systematic nodal sampling. Participating surgeons need to complete and sign a credentialing form where all of that is, they have to answer questions about all these aspects. That's to be found in section 8.1.2 of the protocol, and also a pleurectomy decortication volume form that shows how many of these procedures you have done at your site. The target accrual for this trial is 140 randomized patients. The study opened just before the pandemic hit, and that has certainly been reflected in the accrual numbers because many operating rooms were shut down at first. And I think nationwide and maybe even internationally, we have seen a decrease in surgeries performed for mesothelioma. We do have 13 sites approved currently, and we have accrued 11 patients. And recently we've seen an uptick in accruals, so we're hopeful that it's picking up again. And if this webinar piqued your interest, then please join us for monthly conference calls. We are having monthly conference calls with all the participating sites. Next one is tomorrow at 11. And there we have an open forum to answer questions, address issues, and also try to just, help the sites get patients through the protocol and also identify any areas that may require an amendment. I'd like to mention the MARS-2 trial, which we expect to have a potential impact on our trial. This trial is happening in the UK. The PI is Eric Lim. And this is a study on the role of pleurectomy decortication compared to chemotherapy. So These are patients who are deemed resectable by CT staging, and they have undergone platinum pemetrexed chemotherapy for 2 cycles, and then they get randomized to either undergo this lung-sparing surgery, pleurectomy decortication, or 4 more cycles of platinum pemetrexed. And the primary endpoint is the feasibility to randomize 50 patients in 2 years, and the accrual of this is completed, but they are waiting for more events to determine the survival. And so hopefully this data will come out in 2023. This is what Dr. Lim told me. And if this ends up being a positive trial or a promising trial favoring surgery, that would certainly help, I think, increase the patients that might be interested, and also maybe in the field, the willingness to take these patients to surgery. So we're hoping that this data will come out in the near future. But in the meantime, NRG-LU006 is of course open already and looking at the whole trimodality paradigm for these resectable patients. Here's my email address. If you have any other questions after this, please contact me. Fran Bradley from NRG Oncology is also always extremely helpful in answering any questions that are protocol related, and can always get in touch with me quickly. And with that, I'd like to open the floor for some discussion points. I believe that we have participants from centers that have the study open, as well as some from centers that don't have the study open yet. And so just a few things that I thought of that you might be interested in, or that I might be interested in from your centers is, do you see this patient population? At what stage in the disease do you find that these patients present to your centers? How many pleurectomy decortications do you do per year now? Have you noticed any trends? And what would you identify as potential barriers to accrual? Do patients just get immunotherapy locally, or do they get intraoperative adjuvant therapies that prevent them from going on this trial? So maybe we can just open the floor for discussion right here. I have another slide for the centers that don't have the study open yet, but feel free to just raise issues or raise questions through the chat or by unmuting yourself.
Andreas, perhaps I can add just one point about the MARS-2 study.
Please.
It actually met that feasibility endpoint and has gone on to complete the full accrual, which is, I believe, over 300 patients. A remarkable accomplishment, considering that the latter part of the trial was completed during COVID. So a surgery versus no surgery trial, which is always a tough thing to complete, and then done under particularly difficult circumstances given the COVID pandemic. So we hopefully will hear more on an overall survival endpoint at some point in the 2023 year. We'll see how many events they have and when they're ready to report.
That's fantastic.
Valerie, do you think that for MARS-2 they optimize the accrual in some way that we could potentially benefit from for this trial?
Well, a very committed group of surgeons, I think really a sense of equipoise across the UK, focus on a relatively small number of multidisciplinary teams seeing these patients, and that is one of the benefits of being able to regionalize care as a federally supported initiative in the UK as opposed to this country. And I think the other aspect of this is that from the epidemiology standpoint, the UK is still in a phase where they have proportionately a larger number of patients than what we are now seeing in this country, and they are also tend to be a little bit younger than what we're seeing in this country. And that's just a reflection of the impact of asbestos control measures in this country, which occurred before that happened in the UK. So a combination of all those things, but regionalization of care is definitely a huge plus.
We also touched on equipoise, and I'm a radiation oncologist. I definitely believe in the modality for this cancer, but I almost feel there's more equipoise in should they get adjuvant radiation or not than should they get surgery. So it's really a testament that they were able to accrue MARS-2 so quickly, and hopefully people can see the equipoise and the importance of this study and have that same momentum to enroll.
Exactly, I agree.
So
So you can certainly put questions in the chat or the QA, or you're able to unmute yourself as well. Questions as well as some of these discussion points that Dr. Imner put on here. Any thoughts from anyone?
Maybe we need to expand NRG oncology to the UK now that MARS-2 is completed there.
Attendees can also raise their hand, and that will allow Fran or I to unmute you to talk if you prefer to ask a question that way.
Maybe if there are centers that don't have the study open yet, do you have any questions or concerns about the credentialing? What can we do to help open the study at your center? I see Jim Urbanik and Sue Yom on there on the list of attendees. I'll just call you out since I know you. And I don't think your centers have the study open.
So Dr. Urbanik asked, what is the trickiest part of proton planning? Yeah, maybe I could kind of field that. It is a little different, especially in your center where you would do PBS only, which is really what would be required for a hemithoracic treatment, essentially the equivalent of intensity-modulated proton therapy. We historically in the IMPT world don't think of a PTV, but the protocol does call for thinking through that. So we make essentially a CTV and then margin for motion. But how do we evaluate the CTV as far as planning for protons? So I think that's the trickiest part. I think the protocol kind of walks us through. I know Jennifer's on the call, and she and her team and the physics group has done a great job with the protocol. But I think conceptually, and for people that have done a lot of IMRT, the actual target volume that you're prescribing to is the hardest thing to think through with protons. Dr. Yam asked, is there a rare tumor letter from the NCI giving protection from closure due to low enrollment? Fewer of our patients go to surgery now. Andres?
Yes, we had a letter like that. Fran would know.
Yes, yes, we do. And it is posted on the CTSU website. Anyone that has access to CTSU can access the letter, or I put my email in the chat line. You can email me and I can get you the letter.
Yeah, that's a good point. And certainly in this environment that we are currently in, slow accruing trials or trials on rare diseases that by expectation don't have that many patients need to be protected from closure by the IRBs. So that's why we have that letter. And Dr. Urbanik said he lacks the volume, but would be happy to send his patients out for this. And I think that speaks also to what Dr. Rush said earlier. There are centers. We currently have 13 centers open. The ones that have accrued so far are the Mayo Clinic, Swedish in Seattle, the University of Chicago, Ohio State, the University of Miami, and Baylor, and us at Memorial Sloan Kettering. And so certainly, you know, if you have patients and you don't have enough to open the study, or you don't have enough to meet the credentialing criteria, just being aware of this study and sending patients our way or to a center that has the study open would be a huge help. So that would be greatly appreciated.
One more question from Dr. Biswas. I am from CASE. Initially, our disease team did not want to open the trial. I'll be happy to take it back as our surgeons are quite experienced with mesothelioma surgery. It's great to hear. Thank you.
Yeah, thank you, Dr. Biswas. That would be wonderful. Let us know if we can help you with anything, or if you want us to talk to your surgeons.
Dr. Yam asked a question about current accrual and required sample size.
Yeah, we're at 11 patients, and we're aiming for a total of 140 randomized patients, 70 per arm.
And just one this week was accrued, which is great.
Yep, and one 2 weeks ago. So we have seen a little bit of an uptick. Thank you, Dr. Yam. Dr. Yam said that she'll represent to their group and reconsider. That would be great.
It's really great. Others who haven't had questions, any comments, any concerns about the trial? A new question just came in from Dr. Bryant at University of Chicago. They have a large medical oncology practice. They do around 20 pleurectomy decortications a year. He's first year on faculty and clinically academically focusing on meso, which is terrific. Interested in enrolling, but not sure if he'll be able to because of the 2-year experience requirement. Does that include fellowship training?
Yeah, I think obviously I'm familiar with all the high volume institutions around the country. University of Chicago, right? Is that?
Yes, University of Chicago.
Yeah. So that's an institution that has huge expertise in this area, and even if you're relatively soon out of fellowship, if you've had that kind of training and you're working in that kind of environment, we'd certainly welcome your participation. And so thank you for your interest, and we hope that you'll push ahead and add patients. It's really, we just didn't want to have institutions that rarely do cases and then find ourselves getting into a very high risk of adverse events on the surgical side.
If you enroll 20 patients with an EPD per year, you'll single-handedly complete this trial.
So Dr. Yam asked if Dr. Rush, you could summarize what the perspective of the surgery community is on this trial.
I'm not sure I can speak for the whole surgery community. I think my suspicion is that some of the barriers are that surgeons may not really pay close attention as to when patients should be registered and randomized. And that's where having a multidisciplinary group that really reviews the care plans on a regular basis for all the meso patients in your institutions becomes very important, or at least have that as part of a active tumor board so that these patients get captured at the right point in time and discussed in a multidisciplinary manner. So I think that's one issue. The other issue that we certainly see at MSK is the patients who have kind of partial initial management in the community setting. I'm talking about the surgical management, where they might have had a partial pleurectomy that sort of burns the bridges surgically for a definitive procedure later on, and that's done by surgeons who may not be as familiar with the disease or the treatment options. Or patients who get managed initially by community medical oncologists and are given a significant number of cycles of something, whether that's cis-pemi or ipi-nivo, and sometimes receive, beyond 4 cycles, maybe even 6 cycles of treatment, and then maybe off treatment for a while, and are then referred into the surgeon with a now what. So it's very unfortunate when these patients get partially managed in a community setting before they get referred into a center of excellence. And all of those factors tend to detract from accruing to a study like this. I think for those of us who do mesothelioma surgery, that there's not a strong concern about doing adjuvant radiation. So I think those are probably the factors that have been most problematic for accrual.
Yeah, thank you, Dr. Ruch. I completely agree. And that was part of the motivation for the most recent amendment to allow neoadjuvant therapy prior to enrollment, including chemoimmunotherapy and ipi-nivo, because we had observed that. But we did stick to our mandate to have surgery and radiation therapy done on protocol to maximize the quality assurance and really make sure that those 2 modalities are done very precisely per protocol. So patients have to enroll prior to surgery is the bottom line, whether surgery upfront or after neoadjuvant therapy. And Dr. Yom just confirmed that they also see a lot start something in the community.
There's a question about, can we speak to toxicity signals seen so far?
Maybe more from our previous phase 2 trials. On the phase 3 trial so far, we have not seen any toxicity signal, but it's been only a handful of patients, and only half of them get randomized to radiation, right? So, but on our phase 2 trials, we did not see any terrible toxicities. We had 2 patients with grade 3 pneumonitis that improved with the management of steroids. And we did not see any grade 4 or 5 toxicity, even in the multi-institutional phase 2 portion, where we expanded the modality to 4 other centers. So that phase 2 trial was actually a mandate by the NCI for us to demonstrate that we can export and generalize this technique. And so what we did as part of that trial was we did central QA for all the radiation plans, and that seemed to have paid off because we, as I said, did not see any grade 4 or 5 toxicity from the radiation. We are doing the same thing. I did not include it in these slides since this webinar was more geared towards the surgery question, but we do central review of the contours as well as central review of the final treatment plan prior to starting the radiation. And so both the contours as well as the radiation plan have to be centrally submitted to NRG Oncology and will be reviewed by our team on each and every patient. And we've committed to turning it around within 48 hours. So essentially you can learn this technique on the trial, and we will make sure that your plan meets all the criteria per protocol and give you guidance on that. And that's gone quite well in communication with the centers that have enrolled patients and have had them randomized to the radiation arm. So yeah, we're helping you with that on the radiation QA front.
I'm not seeing any other questions in the chat. Any other discussion points, Andreas?
I don't think so. Dr. Yom, did that answer your question? Maybe, maybe not.
Exciting to see multiple people on the call have expressed an interest in either opening it or accruing more, or starting to accrue with it open. So that's great. Thank you all very much for that.
Yeah, and please reach out to us if we can help in any way, opening the study at your center or help you with any patient-related questions. You can always informally reach out to us, even if you have a potential patient. Just ask us, is this possible? Is this not possible? A question that came up from some other surgeons was whether prior pleurodesis is allowed, and there's no stipulation on excluding those patients. So as long as you feel that you can still perform a pleurectomy decortication, that's fine. But yeah, practical questions like that we may not have all addressed in this webinar, or that may be very individualized questions to the patient in front of you, just feel free to reach out anytime, and we'll be able to answer, or we'll do our best to answer those questions and select the right patients for the trial. If there are no other questions, I would say we close the webinar. Fran, Angela, are there any other things we should address?
No, I will add my email one more time into the chat here. Thank you. That was very interesting, and I hope this was helpful to accrual.
Yeah, then I'll try to get the posting, the recording of this posted tomorrow. I'll get it over to Fran so we can get it out.
Okay, great.
Thank you, Dr. Ridmer.
Yeah, if there are no other questions, have a good evening. Thank you for tuning in, and good night.